Assalamu alaikum. My name is Dr. Khalid Naseeb. I am Associate Professor in NSCVD Council. First, I want to thank all my senior colleagues and give the chance to present the cardiogenic shock and MCS. I think first it is important to understand what is the cardiogenic shock. The clinical criteria of the cardiogenic shock is the systolic blood pressure less than 90 mmHg for more than 30 minutes, or need the inotropic support to keep the systolic blood pressure for more than 90, or evidence of an organ after perfusion, like urine output less than 30 ml per hour, tachycardia, cold peripheries, and etc. Hemodynamic criteria for the cardiogenic shock: the cardiac index less than 2.2 and pulmonary capillary wedge pressure more than 15. The Sky Shock Stage classification have to guide the management of the shock. According to the Sky Shock classification, the shock divided into different stages from A to E. Stage A, the patient of the risk of cardiogenic shock due to massive myocardial damage or the compressive heart failure, but no sign or symptom of shock. Stage B, the beginning of the shock, patient slightly hypertension, systolic blood pressure less than 90, tachycardia, but no sign of an organ hyperperfusion. Stage is a classical cardiogenic shock. Patient has sign or symptom of cardiogenic shock, need of pharmacological or mechanical support to keep the blood pressure above 90 mmHg. Here is the indication of the right heart catheterization, means swan gas catheter. Stage D, duration of the cardiogenic shock, need the multiple inotropic support or mechanical support. Stage E, the steering condition, cardiac arrest, ongoing CPR, pulse-like activity, despite the maximum inotropic support. Look the A, patient at the risk of shock, B, for beginning of shock, C, classical sign of symptom of shock, D, duration of the cardiogenic shock, E, extreme condition. Now, basic talk overview of the importance of the cardiogenic shock team, timing of option for MCS, and feature of mechanical support devices. The idea of dedicated shock team is recently developed. The article published in the JACC in 2019, the standard team-based care for cardiogenic shock. In this study, 204 patients with cardiogenic shock followed by the dedicated shock team and looking for the historical risk match control. The result of this study is very impressive. Here, the cardiogenic shock patient divided into two groups. Blue lines, the cardiogenic patient shock due to ischemia of myocardial infarction, and red line show the cardiogenic shock due to decompensated heart failure. The survival of the before the dedicated shock team, the only 44, which improved into 82%, and cardiogenic shock due to decompensated heart failure, the survival only 60%. After the team improved is the 72%. The conclusion of this study, the shock team improved the outcome of the cardiogenic shock. After that, multiple articles are published, shock team and shock doctors, and JACC article published released the guideline how to shock team approach. The patient cardiogenic shock due to ischemia, the team leader intervention cardiologist activate the cath lab and mechanical devices. Other hand, if the cardiogenic shock due to heart failure, the team leader heart failure specialist. Another article is published in the circulation, shock team approaching the refractory cardiogenic shock requiring short-term mechanical circulatory support. Similar, 123 patients in cardiogenic shock followed by the dedicated shock team, and outcome was compared with the risk match control. Here 2 points. Primary outcome 30 days mortality, and second point shock to support time. Here to clearly they see the survival in the shock team much better than the control group. And what is the shock to support time? The shock to support time means the patient comes with the shock and the time required the insertion of the mechanical device. Those people who disagree with the shock team told that the more time required for activation of team. But in this study, there is no difference between the shock team and other. So, shock team is the much better. In the shock team include the congestive heart failure attending, intervention cardiologist attending, cardiac thoracic surgeon attending, and intensive care attending. Timing and option for mechanical support devices and feature of mechanical support devices. The Detroit Cardiogenic Shock Initiative is the first group initiated after the cardiogenic shock how to measure taken to improve the survival of the patient. This the slide can look the basic characteristic of the patient is a similar, age group is a similar, blood pressure is a similar, inotropes are similar, but lactate level is the similar, but survival rate the much better in the National Cardiogenic Shock Initiative is the 72% compared to other group. The initiative was the early acceleration of its support if needed, use of right heart catheterization, use of cardiac power output and PAPI as a target, early use of mechanical support, and look the vascular complication prior to leaving the cath lab. The Swan gas catheter. The Swan gas catheter known to everyone is a very necessary tool for the right heart cath. The study was performed by the employer as planned. The mechanical support without the use of Swan gas, the survival rate only 48%. But use the Swan catheter before the insertion of the mechanical support device, the survival rate moved into 62%. Another article published in the circulation in 2020, same data, significantly lower in hospital mortality those who right heart cath perform the insertion of the mechanical support device. What is the cardiac power output? In recent years, some novel parameter introduced in the last 4 to 5 years. The cardiac output is a strong hospital mortality predictor. How to calculate mean arterial blood pressure? Multiply the cardiac output and divide by the 451. 451 is the constant value. Is the value the less than 0.6 is the strong indicator of the hospital mortality and tell about the LV function. Each mean can need the mechanical support. Another powerful predictor of the hemodynamic PAPI, pulmonary artery pulse rate index, predict right heart ventricle failure after left ventricular device implantation. Is calculated both easily. Pulmonary pulse pressure, pulmonary artery systolic pressure minus pulmonary artery diastolic pressure divided by the RA pressure or CVP. If value more than 1, it means RV function is better, no need of the RV support. If the value is the less 1, it means the RV function not good and also need the RV support device. This chart is very important. Ensure after the inotropic support, calculate the CPO. If CPO less than 0.6, it means inadequate. Is more than 0.6, it is no need of any mechanical support. Then calculate the PAPI. If value is the less than 1, need the also RV support. If more than 1, no need of the RV support, need only LV support. Understand? Now option of advanced support. Initial option is the intraventricular balloon pump, Impella, LV acceleration device, Impella 5, 5.5, tandem heart, ECMO, surgical left ventricular assist device, or RV acceleration device, Impella RP, or protective tube. Intra-aluminum balloon pump. We all know the use of intra-aluminum balloon pump. Was slightly I'm talking about the intra-balloon pump more than the other device. First, you increase the flow only 0.5 liter. Sheet size much bigger than routine use of 7-8 console pulsation in the descending aura. A mechanism of action that inflate in the diastole or deflate in the systole. Inflate in the diastole, increase the forward flow or increase the coronary blood flow, and deflate in the systole, the section of foot or slightly increase the flow 0.5 liter and decrease the afterload. In different articles shows the no benefit intraballoon pump in after the acute MI in cardiogenic shock. The reason is we are read in medical school the 25% LV mass damage need the patient went into the pulmonary edema and 40% damage of left ventricle need the patient went into the cardiogenic shock. If only increase the 0.5 liter to no take the much difference, and also need the rhythm very stable. In the case of AFib, atrial fibrillation or rate heart rate more than 30, the effectiveness interval very impaired. In cardiogenic 2 trial that show the no such benefit of interballoon pump in shock due to MI. Yesterday discussion about the interballoon pump after the high risk PCI, just like after the bypass, venous graft intervention or left main, unprotected left main. What is the role of interballoon pump? The BIXIS 1 trial showed as such no difference in the max in the hospital stay 3 months and 6 months. Slightly improvement in the after 51 months, but reason mechanism is certain and clear. What is the Impala CP? This is a device recently used all over the world. Increase the flow 3.5 liter, sheet size much bigger from the interbellum form. 14 size sheet required. Is the mechanism of action. The just look like the pigtail catheter. Place the left ventricle. This hole in the left ventricle, suck the blood from the left ventricle and eject the blood from here into aorta. Sucking blood from the left ventricle and machine is here and eject blood in the aorta. So unload the left ventricle. Impala 5 is the sheet side needs the much larger side, 23 French. Is a prohibited to use the femoral artery. It needs the axillary artery cut down and expose the accessory artery, insert the surgical graft with the dicron graft and then insert the sheet to the surgical graft and use the similar one, the Impala graft, Impala 2.5. The advantage of the graft is the maintain the flow to the arm. New device Impala 5.5 is the introduced recently, but price is very high. The sheet size much smaller size, 21 French. The flow increase is 6 liter. But advantage of this is has the optical sensor in the device. We show the position of the Impala device. Here is the left ventricle, not migrate too forward in the LV or not pull to the aorta. So easily monitoring the position of the Impala device. US Impala registry show the PCI of the unprotected left AMA intervention to the benefit of the Impala device. As such, interbellum pump such no study show the any benefit in the unprotected left main in the acute MI. Tandem heart. This device not used routinely due to complexity and increase the flow 4 liter, sheet size much higher, 21 French for femoral vein and 70 French required for arterial side. In this, the arterial side, the femoral vein and go to RA and RA so puncture the center and enter the LA. Suck the blood from LA to the machine, then eject blood to the femoral artery. This device is not routinely used. The only use is those patients with a prosthetic valve in the aortic valve position. You don't want to cross the aortic valve and damage the prosthetic valve. RV support devices. Impala RP, just like Impala left side device, Impala RP insert through the need the 21 French each side, insert through the femoral vein and then cross the RA, RV and pulmonary artery is the here. So suck the blood from the IVC and eject the blood in the pulmonary artery independent of right ventricle function. But it is still not FDA approved and limited data for this device. Other device, the protective dual drive, is need the 31 French sheet and calculate through the interjugular vein. And with a nice curve, you cross the jugular vein, RA as the RV and place in the pulmonary artery. Here the suck the blood from the RA and inject blood into the pulmonary artery independent of the right ventricle function. This device is the FDA approved and much better outcome of this device. ECMO is a powerful device, very powerful device. It's use of both biventricular failure, RV and LV failure can use this device. But main thing is the sheet size and cost is very. Here the sheet size of the femoral side is 25 French and arterial 70 French sheet size. The place the sheet from the femoral vein to RA, SVC, and femoral side the descending rotafemoral artery. Here the suck the blood from the RA, oxygenated from here, then machine to eject blood into femoral artery or descending aorta. This device increases the flow at least 7 liter. So powerful support of the patient. Remember, two devices increase the coronary blood flow, interbellum pump and Impala. Other device not increase the coronary blood flow. Feature of MCS. Last 2 days back, yeah, 1 week back, I was talking about what is the unloading. Important of immediate MCS door to unload. Unload the left ventricle before reperfusion in patient with interior ST segment elevation MI. Here two groups are divided. One group is a control. The patient came in the ER with the extensive interval MI and normally give the ACS protocol and shift the cath lab for primary PCI. This is a control group. And other group, the patient come in the ER emergency with the extensive after MI, give the ACP protocol and unload the patient through the impella for 30 minutes and then shift to the cath lab. What is the unload the left ventricle? The school of thought is that can prevent the perfusion injury and cardioprotective mechanism and smoothly filling, diastolic filling of the left ventricle descending artery. Initial result very supportive the treatment group. Unloading group, the result is much better than the reperfusion strategy. The trial is ongoing. In the 2 years trial, the group result, the unloading group is much better. The application of ECMO used during the CPR show the more benefit of the CPR. Arrest trial. In arrest trial, the CPR to place the ECMO during CPR in the cath lab and those patients the CPR in the ER. Now total in the 36 patients in 10 months duration. This trial is terminated in the early due to ethical groups. The conventional CPR the survival rate only 7%. Compared to ECMO group, the survival rate is 46%. The conclusion, cardiogenic shock and complex high risks are associated with the high incidence of morbidity and mortality. Team-based approach for shock, conscious use of the right heart catheterization, use of reductor power output, and pulmonary artery persistence index assay. Treater, early use of mechanical support. Most important, intervention cardiologists need to understand a specific indication, contraindication, device placement, and post-placement monitoring techniques. Thank you.